So we are going to move to the next talk and also to the next chair because unfortunately I have to leave. So Valérie and Laura has nicely agreed to be a chair after me. So the next talk is by Berna RAHI. Berna is a postdoctoral fellow here in Bordeaux, working on nutrition, biomarkers, and therapeutic risk in older adults. She had a PhD last year from University of Montreal, and as part of a thesis, she studied the roles of diet quality and physical activity in preventing functional decline in diabetic older adults. And now I think you're going to present some results of your postdoctoral your thesis or doctoral stage. Oh, sorry, yeah, it was written, I can't wait.
Hi again, thank you. Hi, and thank you again for inviting me. So today I'm going to present part of my thesis results, which are the roles of diet quality and physical activity in preventing functional decline among diabetic older adults. So the outline will be presenting to older adults within the concept on functional capacity and diabetes, functional capacity and nutrition, and physical activity. And then I'm going to present the objectives, the methodology, results, the strengths and limits, and finally conclude. So older adults are prone to physiological changes during aging, which increase the risk for chronic diseases and in particular type 2 diabetes. In addition, they have loss of muscle mass and muscle strength due to the aging process. They have compromised functional autonomy and capacities, and above all, they have a modified nutritional need, which put the strength on the nutrition to play as a major role in successful and healthy aging. Diabetic older adults are an important group of diabetic people. In fact, they are the biggest group of diabetic people, and they have complications which are increased within their age and the duration. Diabetes is a major cause for premature mortality among older adults, and diabetes in older adults place these adults at an accelerated aging. They have an increased risk of muscle mass and strength losses compared to their non-diabetic counterparts, and then they are at a 2 times higher risk for functional decline. And again, nutrition and physical activities have major roles in diabetes. They have a well-established roles in diabetes management. Functional capacity in older adults. We have several risk factors, which is aging itself, diabetes, muscle mass and strength losses, low level of physical activity, and the nutrition in part of high and low BMI, weight loss, nutrients, dietary patterns, and diet quality. So, why diabetic older adults are at a higher increase of functional decline? We have non-modifiable risk factors, which are age, diabetes duration, and genetic predisposition. And we have several potentially modifiable factors, which are diabetes-related comorbidities like peripheral neuropathies, coronary diseases, visual impairments, stroke, and poor glycemic control. They have diabetes-associated comorbidities, which are obesity, cognitive impairments, dementia, arthritis, and pain. And we have several other factors like sarcopenia, poor muscle quality, systemic inflammation, and oxidative stress. What is the role of nutrition in functional capacity? I stated that we have nutrients, food groups, and dietary patterns. I'm going to start with nutrients. We have a protein intake, which is known to affect functional capacity, although studies on these nutrients are right now scarce. We have also the role of musculoskeletal nutrients like calcium, magnesium, phosphorus, and vitamin D, which are known to prevent and protect from functional capacity decline in older adults. And we have the antioxidants nutrients, which are vitamin E, vitamin C, vitamin A, beta-carotenoids, and selenium. Other than nutrients, studies have focused on food groups and their role in functional capacity decline. We have the blue ones. They play a protective role against functional capacity decline, dairy products, mainly due to their musculoskeletal role. We have the fibers, the N3 PUFAs, fruits and vegetables, while it has been shown that cholesterol, lipids, and saturated fatty acids are detrimental to functional capacity decline, partly due to their oxidative stress-inducing capacities and inflammatory responses they induce. However, studies now are focusing on dietary patterns and diet quality, just for the fact that nutrients and food groups aren't consumed alone. They are consumed within a pattern, and there are characteristics and interactions between all the nutrients taken. Therefore, we have determined in the literature 3 types of dietary patterns or diet quality that were shown to affect functional capacity. Although I have to say these studies and this topic is a bit new to the field, and there are not lots of studies that are assessing this relation. So for the dietary patterns, we have the Mediterranean diet, which was proven to improve and to prevent functional capacity decline majorly in terms of mobility. The prudent dietary pattern also was shown to be protective because the prudent dietary was high in fruits and vegetables and in fish intake, which are N3 PUFAs. And recently, a new study showing the effect of Healthy Eating Index 2005 as a preventive of functional decline in terms of ADL and IADL in the Enhance study. Therefore, we can see that there is an interrelationship between aging and type 2 diabetes, an interrelationship between aging and functional capacity, and type 2 diabetes, which increases the risk of functional capacity. And we see that nutrition plays a major role in the center of all these diseases, in all of these, in terms of aging, which introduce a healthy aging, in terms of controlling diabetes, and in preventing functional capacity. So the role of studying nutrition in particular is really interesting. However, I have to mention that all these studies that are done in nutrients, dietary patterns, or diet quality are among the generally older adult population, and it's not specific for any population like type 2 diabetic, older adults, or patients with cardiovascular diseases. So these associations apply to the general older population. Now to the role of physical activity, which also enhances muscle mass maintenance, muscle strength maintenance, and leads to slowing sarcopenia progression. Physical activity has a role in better diabetes management, and it was shown that it prevents functional capacity decline and it helps its maintenance. Either it's in aerobic activities or either it's in muscle strength activities. So what is missing in all these associations? I have shown you that diabetic older adults are at an increased risk of muscle strength loss and at increased risk of functional decline, and that nutrition and physical activity affect muscle strength losses, and functional decline is modulated by nutrition and physical activity. But the only part missing is that these associations are not studied in the diabetic older adult population. They are studied in the general older population. Therefore, the missing is the specific sample of diabetic older adults. And here what I did in my thesis. So we had a secondary analysis of the new age cohort. It's called the nutrition as a determinant of successful aging, the Quebec longitudinal study. It was in Quebec, Montreal. We had 2 times of interest at T1, the inclusion date, and at 3 years of follow-up, which is at T4. The NIASH consisted of 1793 participants aged 67 to 84 years old. The inclusion criteria insisted that the participants should be in general good health. When we wanted to work with diabetic older adults, so we selected our sample, which consisted of 243 patients, which had self-reported diabetes, current use of oral hypoglycemic medications or insulin, and since 20% of older adults might not know that they are diabetics. While they are diabetics, we chose to assess diabetes while using the fasting plasma glucose concentration, and you had 17% of the 243 patients which were diagnosed with diabetes, while they didn't know that they are diabetics. So our variables of interest are the dependent variable, which is functional capacity, which is measured by the SMAF. It's a Système de mesure de l'autonomie fonctionnelle. It's a Quebec measure used mainly in Quebec, validated and developed by a Canadian researcher. It measures 5 domains. It measures 5 domains of capacity: the ADL, IADL, capacities in communication, mobility, and mental functions. It has 29 questions, and it's scored from 0 to 83. The higher the score, the more you are declining. We have functional incapacities. Our intermediate variables were muscle strength in hand grip strength, biceps, and quadriceps. Our independent variables were the diet quality, measured by the Canadian Healthy Eating Index. It's also a measure of diet quality based on how people conform to the Canadian dietary guidelines. It is also developed and validated for the Canadian population. We assessed the protein intake, energy intake from 3 24-hour dietary records, and we assessed physical activity via the PACE physical activity scale for elderly. And we adjusted our analysis for several confounding factors: demographic, social, anthropometric, and cognitive. Since we were also interested in finding the effect of combining diet quality to physical activity, we created a variable that combines the two. So we dichotomized each variable and combined them. Low versus high diet quality, dichotomized to the median, and then we assessed the change of physical activity, decreased versus increased and stable, and then we combined all these 4 categories. We first assessed muscle strength and diet quality, and we found that when we combined diet quality to physical activity, we found that the group with the high diet quality and the increased or stable physical activity had the lowest decrease in hand grip strength, and therefore these factors were protective against losing their strength. These results were shown in men only. In women, we had a small sample size of 60 women, and we lacked the effect in the. And also we found effect on the elbow flexor strength, also in men, but this time we found only a difference between the low diet quality versus the high diet quality group, which indicates that in this case, diet quality played a role in preventing strength losses in men, in diabetic older men. Second, we assessed the diet quality and physical activity and their effect on functional capacity. Unfortunately, we couldn't find any effect. In all these categories, the change in functional capacity was almost the same, and we couldn't find any effect. And third, we wanted to assess energy and protein optimal intakes and functional capacity. Why? Because diet quality does not directly assess energy and protein intakes. It exerts its effect independently. Diet quality is measured by several intake of food groups in addition to cholesterol, sodium, and sugars, while we control for energy intake. So, since the studies also showed that protein intake is a major contributor to functional capacity, we wanted to assess its effect. And therefore, we set optimal energy intake at 30 kilocalories per kilogram body weight per day. And we showed the optimal protein intake at 1, which is higher than the recommended of 0.8, because we reviewed several studies, and it was shown that 0.8 might be low might be a low recommendation for older adults due to their increased need, and we recommend an intake of at least 1 gram of kilogram body weight, and therefore we set it at 1 gram per kilogram. What we found was interesting, since we found that optimal protein intake was effective in preventing functional decline in women only. And this effect might be due to maintenance of knee extensor strength. Also, we found this only in women. While in men, we initially found the significant effect. Energy intake was effective in preventing functional decline, but when we adjusted for weight loss, we lost our effect. And therefore, we discussed that we have two different mechanisms, and they are gender-based. Therefore, to discuss all these results, we found that neither diet quality alone nor combined with physical activity were associated with functional decline over the 3-year follow-up in diabetic older adults. Why is that? Because of the characteristics of our sample size. First, we had a relatively good adherence to dietary recommendations. They had a mean CHEI of 70, which is relatively good. We found that our participants practiced physical activity, and in fact, they maintained these activities over the 3 years of follow-up. Other baseline characteristics were protective against functional decline. They had a good social network. They maintained their physical. They maintained their muscle and mass muscle strength. They weren't at risk of depression. They had good cognitive functions. So all these factors helped maintain their functional capacities. We also found that muscle strength losses were comparable to those observed in non-diabetic older adults, and their physical performance was also maintained over the 3 follow-up. In fact, at 3 years of follow-up, they had a walking speed higher than 1 meter per second, which is the threshold at which functional capacities start to decline. So we had a speed of 1.3 at 3 years of follow-up, which indicates that this was a sample in a very good health. And also we found that the change in functional capacity as measured by the SMAF was clinically non-significant. A clinical significant decline is when we have a 5-point change or more, while we had changes within a mean of 3.4. So all these characteristics might have explained why we didn't find any statistical significance, since participants were highly functional over the 3 years of follow-up. For the effects of optimal energy and protein intake, we found that they differed by sex, and then we discussed that it might be that optimal protein intake might have protected against functional decline in women via effects on muscle strength, as we showed that protein intake maintained knee extensor strength, while the relationship between optimal energy intake and functional capacity might be modulated by muscle mass in older men. What are the strengths of these analyses? We had a choice of diabetic sample, which the literature lacks studies in this sample. We were among the first to examine these associations, to combine diet quality to physical activity in a diabetic sample. We had longitudinal analysis over 3 years of follow-up. We had detailed information on several confounding variables, and diet quality was assessed via the Canadian Healthy Eating Index, which is specifically developed and validated for the Canadian population. However, we had also limitations. We had a small sample size, 243 diabetic older adults, and with the elimination of missing variables, we ended up by between 170 and 180, depending on the analysis. We had a short follow-up of 3 years, which not allowed our participants to literally decline in their functional capacities. They were included, and the inclusion criteria were that they had to be generally in a good health, and then they had characteristics which protected them. So the 3 years follow-up was not enough to determine a clinically decline. Unfortunately, we had no available information on several key variables that might have modulated our results, like diabetes duration, which is an important factor, an important modulator on all these functions. We had no information on drugs taken. We had information on the number of medications, but not on the type of medications taken, which also might have affected our results. We might have a selective survival. In fact, those coming back to the 3 years of follow-up, they were a little bit more strong than those missing. And we had a selection bias at first, since the inclusion criteria insisted that the people were generally in a good health. They had a 3MS score above 27, so they were practically in a good health. And it might be that we had an underreporting of food intake. Generally, with any food study, we have underreporting, but still with the underreporting, we found some effects. So it might be that even with the no underreporting, our results would be more strong. Therefore, to conclude, diabetic older adults are advised to follow nutritional recommendations as stated in the Canadian Healthy Eating Index and in any dietary recommendations, to have an optimal energy and protein intakes at least set at 30 kilocalories per kilogram and 1 gram per kilogram respectively, and to practice physical activity. While following these recommendations, older adults ensure a better diabetes control, minimize the risk for functional capacity decline, and finally, they increase their chances of an independent and a good quality of life. Thank you so much.